Rita, hi. So your audio is doing nice. Okay. You're in a pretty quiet location. Do you have headphones on?
No headphones, but it's fine.
Thank you. Thanks for making the effort.
Yeah.
All right. Let's do the talk first. Get myself organized here. I want to go back to Zoom, do screen share. And now let's get this going. And are you seeing the full slides?
Yes, I do. Sorry, I just had to unmute myself so that way you don't get interrupted.
All right. And Ruby's supposed to be on in 10 minutes, so that's great.
Okay.
Nice. Good progress here. Okay, so what's happening is, we're building up this liver service and trying to keep liver patients at RMC unless they really need to go to Stanford or UCSF for care. And that would basically mean they have something we don't, which is basically transplant. I don't really know of any other services. Nobody has an artificial liver. And I don't think there's any protocols at Stanford or UCSF for our acute liver failure patients, but I'll continue to monitor that. Does that make sense? And what we're going to do, yes, Rita, to try to move this through the hospitalists as well. The hospitalists were supposed to be on this call today. I don't know what happened, but I'm going to work out with Huma.
Yeah, unfortunately, we have like over 80 COVID patients, and the hospitalist teams are pretty impacted with the volume of their census. So they're carrying 8 to 10 COVIDs per team. So it's just making it really tricky right now.
Thank you, and be very sensitive to that. I'm assuming this may not ramp up till a little bit closer to March, but at least you and I and Ruby are going to work together on it.
Correct.
The hospitalists have a great attitude, so we'll bring them in a little bit later. It's nice, good people. So I'm going to move quickly through some of these because you probably know a lot of this, but then I'm going to focus on what I think are pearls and teaching points. Does that make sense? The difference between enzymes and function, and we're using this terminology and trying to teach everybody this terminology. And whenever you have a bilirubin that's above 0.7, you should be asking to fractionate that on the inpatient service. And very importantly, which is not on this slide, is on liver function, is getting the TEG test done. We'll have another talk about that, but do you know how to order TEG?
Yes, I have ordered it.
Okay, fantastic. So we're going to replace the INR with TEG in our liver failure patients. Or you'll probably still get the INR, but we're going to focus on the TEG. And factor 5 for acute liver failure patients. Bicarb, that's a good liver function test because the acute liver failure patients tend to get acidotic. We need to fix that. Factor 7 is also a good prognostic marker of liver function or dysfunction. And as you'll hear me talk about over and over, that anybody who tests ammonia is more confused than their patient. So I really don't care what their ammonia test is. We're going to talk about mental status, asterixis, serial 7s, oriented times 2, 3, 1, etc. So that's really the brain's the liver function test there. And another good liver function test is the blood pressure. So if somebody's got a normal blood pressure, their liver failure is not too bad. It's interesting how blood pressure is on that list. So this is the ammonia story. A lot of people are ordering it. We're going to try to teach people not to order it so much, or maybe even stop eventually. The only time I ever check ammonia is in somebody with normal liver tests that's in a coma when I'm thinking they may have a urea cycle deficiency or some really weird metabolic disease. Any questions on ammonia testing?
No, I do know the hospitalists tend to trend that, which I don't know if it's even, I think clinically is a better gauge, but it is a lab that a lot of the hospitalists will order on admission, and then sometimes some of them will continue to trend it.
The big challenge is they tend to treat the ammonia, not the patient, and then they get tons of lactulose, and then they get candida, then they get acidotic, and then they're vomiting, they're not eating. So if we get the ammonia off the schedule and they look at the physical, we won't poison our patients with lactulose. That's one of the upsides of taking ammonia off, but I'll work on convincing them. It'll take a while.
Yeah.
It's a lifelong commitment I have. All right, every day on your inpatients who have cirrhosis or acute liver failure, in your note, you should be marking their CTP score and their MELD sodium score. And I'm sure you're aware of the CTP score, but we really want to know what that score is. It's like part of the vital signs. And
right.
Important thing to do. You're probably doing that, but just want to reinforce. So I'll be looking at your notes and double checking that. The encephalopathy grading, so level of consciousness, personality, asterixis, incoordination, falling, trouble speaking, oriented, of course, times 3, 2, or 1, like we talked about, aggressive behavior, are they somnolent? So we'll need, at least 3 or 4 words on these patients each day just to gauge them. And asterixis, you should check that every day on each patient. And MELD sodium, this is just the old MELD score. You're familiar with that. You know where to get the calculator, right?
I do, yeah. Use it frequently.
Love it. Sodium MELD, most important. And this is the sodium MELD scoring. So I'll just click through that. So obviously, if the MELD's over 15, we think about a liver transplant referral, MELD over 25. And if they're a candidate, meaning we decide they're a candidate, alcohol, drugs, psychosocial, age, comorbidities. So these are just some simple rules, but our goal is to try to keep these patients at RMC as much as possible. And we will be able to do that because we can do just about everything at RMC with your help. Okay, hepatorenal syndrome, rising creatinine. Very, very simple rule. If you see a 0.3 rise or more on the creatinine, time to start talking about interventions, which is stopping diuretics, giving volume, especially volume with albumin, double checking for obstruction. You get a renal ultrasound, abdominal ultrasound. So we'll get into that a little bit more, but it's that 0.3 delta in creatinine that's absolutely critical. Obviously, you're going to check for GI bleeding. We just talked about diarrhea. I've seen what looked like hepatorenal syndrome from lactulose toxicity. Obviously, you got to take a renal history. Did they have diabetes, chronic kidney disease in the past? How big are their kidneys? Urinalysis should be bland in these patients as well. So you exclude everything else. You've got this issue about no response after 2 days of diuretic withdrawal and expansion. So this albumin, I just like to give the rule of 25 milligrams times 3 doses over 24 hours. You can go up to 100 grams max in a big person. Double checking blood pressure. One thing I really like when I'm talking to you and Ruby is to say, and I need to check and see if Ruby's trying to get in. Well, she's not showing up here. I'll wait till she texts me. Kind of watching the, let's see. Yeah, I don't think she's showing up yet. Okay. Giving albumin, blood pressure. When you're describing blood pressure, I'd like to hear the numbers and the word stable, but I want to hear the numbers first. And let's see, Ruby's coming in. Okay. All right, Ruby. Ruby, are you in a place you can see some slides? How are you?
Yes, I am. Thank you.
Okay, good. We're on the AKI cirrhosis hepatorenal syndrome right now. The key message on looking at creatinine is that the creatinine has changed by 0.3 milligrams per deciliter. That's signaling a workup, intervention, stop diuretics, give volume, give albumin, double check blood pressure, make sure they're not getting anything nephrotoxic, no non-steroidals. There aren't that many nephrotoxic drugs we use anymore, but good to double check the list, get a urinalysis, abdominal ultrasound, including the kidneys and bladder. You want to make sure that they're not obstructed in their bladder. There's a very fancy slide, but what I want to just mention a couple of things on here is every person with cirrhosis needs to have a cardiac echo in their chart. And I don't know how automatic that is for the two of you, but I want that to be on your radar because there's so many types of cardiomyopathy the liver can cause, or the heart, if there's cardiomyopathy causes liver disease. And then if we're thinking about putting in a TIPS, they need to have an echo. If we're thinking about a transplant, they need to have an echo. So it's easiest just to get an echo on your cirrhotic patients that are in the hospital, or make sure they have an echo in their chart somewhere in the last 6 to 12 months. The only other thing that's interesting on here is that this acute kidney injury, HRS or HRS type 1, we used to call this, is this whole issue about bacterial translocation and the change in the biome. There's a lot of research going on about doing fecal transplants for all these different types of liver diseases. It's not something we're going to do at RMC immediately, but it's interesting how much the biome is interacting with the liver and the kidneys and the heart and everything. All right, so progressive renal failure, patient got volume, got albumin, stopped diuretics, creatinine's now 2.5. There's some hidden slides in here, so this is just kind of an update. Blood pressure is falling to 80/40. You're discussing a kidney consult, renal replacement therapy. And it's a question I have for the two of you. Is CRRT easy to get at RMC?
CRRT usually you can get as long as the patient meets the criteria that they're hypotensive, needing pressors, and their sort of end stage liver disease, or their sort of status is not cirrhotics. They tend not to, put it like this, the cirrhotic, if you're cirrhotic decompensated, you're not going to get CRRT or hemodialysis.
Right, so we're going to be changing that. We're going to need to talk to the kidney service. So the number one thing is people have cirrhosis and they need renal replacement therapy. Nobody should get dialysis. Let me just give you that simple rule. But everybody should get CRRT as long as we think they have reversible liver disease or they're a transplant candidate or both. So if the renal service standard is just to say no to everything, we'll need to have some very active dialogue about that.
So I should correct myself. They don't say no to everything, but if someone's end stage liver and the big picture is their overall prognosis is poor, they're less likely going to be getting dialysis or CRRT.
So do you think that they're being obstructive or conservative or reasonable?
No, I think they're being, they take each individual case by case. We've had certain people who are just overall, their prognosis is just very, very poor and it's not going to help. And therefore they don't offer it, but they're very reasonable and they take each individual case uniquely to each person. So it's not a blanket, but they do have their, if you're cirrhotic, you're less likely going to get dialysis.
Okay, so we'll take it case by case. That's good. All right, so look at this case just for a second. Hypotensive, 80/40, rising creatinine. You're thinking about ICU, you're thinking about pressors, you're thinking about renal replacement therapy, but what's missing from this story that the two of you need to think about in every cirrhotic, especially if they're have low blood pressure? It's your mystery question for the day.
If they're third spacing, you mean if they have ascites or?
There's this case on the screen right now. You should be thinking immediately about a one-word diagnosis. Right, we'll fill in the blank. It's called hepatoadrenal.
Adrenal.
Have you heard of hepatoadrenal?
I've not heard of hepatorenal. Hepatorenal or hepatoadrenal?
Adrenal.
Adrenal glands, hepatoadrenal. Have you heard of
No.
that?
I may have and not retained it.
Adrenal insufficiency is found in 50% of cirrhotics who are hypotensive, especially if those patients are in the ICU and you either have or you're thinking about pressors. 50% are adrenal insufficient. So what do you do for adrenal insufficiency? Solucortef. So 60 Q6, 80 Q8 for 3 days is now standard of care for a patient who looks like this. So we'll talk about that as you all are doing consults, but that should come up to be a top line item in these complicated patients now in your practice. We'll have another talk about hepatoadrenal, but I want that to be a hot topic. Does that make sense?
Yes.
Yes.
Good. This is state-of-the-art hepatology we're talking about today. So we got dopamine, we've got norepinephrine, we've got MOA. So in this case, my choice would be number 3, albumin, put them on midodrine, titrate the midodrine up as a pressor, start the octreotide, and then see what their blood pressure response is, see what their renal output response is, see what their creatinine response is. That make sense?
Yes.
Norepinephrine is much preferred to dopamine. So dopamine is a little bit of a trick on here. And another trick on here is terlipressin just got turned down by the FDA to get FDA approved in the US. But I will tell you that terlipressin is available in at least 70 or 80 other countries around the world right now, including all of Europe and all of Asia. It's a long story. Terlipressin should be the standard of care. It is definitely better than octreotide for hepatorenal syndrome, but long story. But the bottom line is this item number 3 that's on here. So we're going to give albumin, norepi, not dopamine. So people are, give me just 1 second. Uma just told me, okay, we will reschedule. Thank you. All right. You're busy, as you said. Midodrine, you can titrate up to 10 milligrams Q6 or 12.5 Q8 for these patients. It's really good for blood pressure support. It keeps a lot of patients off pressors. You put them on midodrine, you give them Solucortef, you can help a lot of patients that way, sometimes even keeping them out of the ICU. So midodrine, well, this one says you can go up to 15 TID, and you want to just keep that systolic pressure around 90. You've heard those numbers before?
I have, yeah.
The standard for octreotide is sub-Q, not IV. It's a lot cheaper to give the sub-Q. It saves on pharmacy dosing, pharmacy costs. Terlipressin, we're going to skip over because it's not around yet. So we get terlipressin, you'll have a whole study. You'll have a whole discussion on terlipressin. Not ready for prime time. Let's see if there's anything else in here. Yeah, let's make sure that's norepi, not dopamine. So do you have any questions on AKI-HRS, AKI, or AKI-HRS? That's the new term for type 1 hepatorenal syndrome.
No. This is useful, very useful.
Let's see, GI bleeding in a cirrhotic. You probably are all super expert at this, right? You stop the bleeding, you give IV antibiotics in all GI bleeders who have cirrhosis, right? But here's a question: are you all doing the paracentesis or is it radiology?
Radiology.
Radiology will do an ultrasound guided.
You order it at 8 o'clock at night. Order at 8 o'clock. When does that paracentesis get done?
Usually the following day.
But that falls below the standard of care. Okay, you've got a patient who's having chest pain. I'm just using this as a little bit of a metaphor. Someone's got chest pain. Would you ever say, oh, the EKG machine's not around, we're going to do the EKG in the morning? You wouldn't do that?
No, No, but I think a lot of times these patients that get admitted overnight, and then it's just the radiologist who has to be available to do the procedure that makes it tricky on timing.
So we're talking about changing the world at RMC. This is not going to be tomorrow, but in the real world, in a real liver service, you have a portable ultrasound. The two of you would do that paracentesis and have it done within an hour. You don't need an INR, you don't need a platelet count, you just need an ultrasound probe and a needle. Well, you need the kit, but that's the only two key items that you need. And you can do it at the bedside. There's ultrasound devices that will actually fit on your iPhone now, believe it or not. So you need to get the standard at RMC up to get that ultrasound paracentesis done within an hour or two of getting them admitted. That's a long-term goal.
The other thing that we've noticed or pushed back on when it gets done is if the INR is significantly elevated, radiologists are requesting that it be closer to 2 versus 8.
There is no data that that has any effect other than harm to the patient. So Mayo Clinic, they did 1,000 paracentesis. They ignored the INR, they ignored the platelet count. They were all done by a physician assistant. And I think they had 2 complications out of 1,000 without any coag support. So the standard of care, don't worry about the INR, don't worry about the platelet count, have an ultrasound, take the fluid out. So we'll work on that. I'm just going to tell you what the goal is as we build a better liver service. That make sense?
Yes.
Yeah.
Evidence. Number 2, when they do a paracentesis, are they putting fluid in blood culture bottles at the bedside?
So there's no bedside paracentesis. It's all done in radiology. I don't know what they're putting it into. I personally haven't observed what they're doing.
So when you order a paracentesis, I need you to order that they take out fluid and put it in blood culture bottles immediately in radiology at the radiology bedside. That is standard of care, has been for 30 years, but it just isn't done unless we advocate. The reasoning is, and this is data driven, is that when you take the fluid and you send it to the lab, the bacteria are all dead by the time the micro lab starts processing the fluid, and you miss all the infections. If you put it in blood culture bottles at the bedside, you will pick up 70 to 80% of the infections. So you'll have a lot of people who look like they have SVP, but they're culture negative because they did not handle the fluid correctly. So let's do that short term, is just see if we can get them to put it in blood culture bottles. And if they're not doing it, then I'll talk to whoever the head of IR is. That make sense?
Yeah.
I know that sometimes the emergency room also does that, and I also don't know how they handle it. It's usually done by the emergency room physician.
We'll work on the emergency room as well to get this as the standard. Once you show them the data and you show it's in the standard of care, it's in the guidelines, people usually acquiesce and will join our system. So got things to work on. That's the goal of our program, right? GI bleeding. We all know about antibiotics, you know about octreotide, you know about endoscopy. My message on here is move from IV proton pump inhibitors to oral proton pump inhibitors and get them off the PPIs unless they really need them at discharge. Proton pump inhibitors increase the risk for SVP, they increase the risk for C. difficile, they cause magnesium wasting, all sorts of problems with proton pump inhibitors. So we really don't want to use them unless they've got peptic disease. Another message, early tip shunt for GI bleeders. So banding, they start oozing, let's order a TIPS, provided that their MELD score is less than 23. The bilirubin rule for MELD is interesting. It's not the bilirubin in the hospital that matters because they've been GI bleeding. That's going to push the bilirubin up, right? It's the bilirubin before they came in. So if we can find outside labs, the bilirubin on outside labs before they were admitted is less than 3, then you can put in a TIPS, even if the MELD is 25 or 28. Make sense?
Yes.
How good are your radiologists at getting TIPS in quickly or without problems or without complications? I think they're good, right? Isn't Lindsay Pierce one of the people who's doing those?
She's one that I've heard of. I think they all do them.
Yeah,
Nice.
Dr. Patadar.
I think Angelescu, Patadar, Lindsay Pierce. I think they all do TIPS.
Lovely. All right, so low threshold to do TIPS for GI bleeding, low threshold to do TIPS for ascites. TIPS have all sorts of great benefits on liver function, on nutrition, avoiding paracentesis, preventing recurrent bleeding, improving at least short-term survival. Of course, you have to treat the underlying liver disease, but okay, let's see. Beta blockers have gone in and out of style. Now they're back in style because it looks like they not only decrease bleeding, rebleeding, but they actually improve survival. If 2 things are negative. They don't have significant ascites, so moderate to severe ascites, no beta blockers. Cardiomyopathy, no beta blockers. So it goes back to having an echo on these patients and looking at that echo before putting them on beta blockers. There is this move by Abhishek and Ruel to start doing this pressure measurement that you may have, you saw some of the email traffic about that, I think, right? The Cook device.
Yes.
Anyway, it's the way to measure it. That's not happening yet because Cook did not get a code that had reimbursement. And RMC is not going to take the hit for the cost of the catheters and not get reimbursed, which I'm okay with. But this may come back in terms of measuring those pressures and guiding therapy eventually. Cook needs to get their act together so this gets paid for. We're not supposed to be subsidizing Cook, you know? Ligation, preferred. I don't think anybody does sclerotherapy at RMC, right?
Not that I've run across. I don't know if Ruby has.
No, not that I'm aware of.
Good. Sclerotherapy is 13th century. NG tubes. People come in with GI bleeding. I'm assuming people put down NG tubes, clear out the blood before they scope patients. Is that right?
Not unless they're actively having hematemesis or there's some sort of bowel obstruction associated, but not usually dropping NG tubes on every upper GI bleeder.
So they'll scope them, but what if the stomach's full of blood? They take out the scope and lavage and then rescope them?
No, they will just say go in and then they see full of blood. Usually before they do the procedure, we either do Raglan or erythromycin.
Oh, okay, that's good. Nice. All right. Anybody ever used a Minnesota tube? Either of you?
No, not for
I
me.
have not.
I've put in a lot of these tubes. It's very exciting. That's probably good news because really these have gone out of style because if you think someone needs a Minnesota tube, you end up putting in a TIPS in most of them. I would say the only role for this is you can't control the bleeding with endoscopy. They're not a candidate for TIPS and they're unstable. But if you don't even have this at regional medical center, then we'll only talk about it if you have it. Maybe one of the two of you could just check and see if there are any Minnesota tubes anywhere around RMC. That would be interesting. You could shoot me an email if you find it or you don't find it.
Okay, I'll ask.
That'd be great. You all know about TIPS, right? I don't need to go over any great detail here.
Yeah, I'm familiar.
Yeah.
All right. Ascites will, well, you know, someone's got hypoxemia, hepatic hydrothorax, you need to be in the ICU. Preferred, you do a thoracentesis, then you put in a TIPS. Chest tubes are just really archaic and really, really troublesome. So really it's tip shunt for hepatic hydrothorax, serous, hypoxemia, pain. TIPS is really the way to go. And let's see, anything else on ascites? We talked, oh, when you do the paracentesis, you order a paracentesis, they get a cell count, right?
Yes.
With differential. So the textbooks say that the neutrophil count has to be over 250 to be SBP. I believe that's wrong. In my opinion, it should be anything over 50 for the neutrophil count is SBP. That's from 30 years of experience. So just a little take-home pearl. Cell count differential, albumin, total protein, blood culture, and blood culture bottles. Those are the 4 important tests. There's a lot of other things on here that you might do. You think they have tuberculosis, you think they have cocci, you think they have cancer. The fluid is cloudy, you're going to send a triglyceride. The fluid is yellow, you'll send a bilirubin. The other tests on the right side, the optional and rare, are just, you're not going to order very much. Albumin, as you know, people have SBP. The standard of care is to give albumin. I still use that, simple rule, 25 times 3 over the first 3 days. Large volume paracentesis, give albumin to support. So for every liter that's taken off, you should give 10 grams or 12.5 grams of albumin. No fresh frozen, no platelets, unless the TEG is markedly abnormal. We'll talk about how to use the TEG to decide what to do. Sound good?
Yeah.
TIPS, you all know about TIPS. We talked about that. There is another special test that's called BRTO. I need to check with Lindsay Pierce to see if they do BRTO. I'm going to send her a text right now. You know what BRTO is? Heard of that?
No.
I have not.
No.
That'll be another talk that we'll go over, but it's balloon retrograde transvariceel obliteration or transvenous obliteration. But I'm going to see if Lindsay ever does those. Okay, little text message conversation. All right, so we're going to shift to acute liver failure. So that goes along with the patient Ruby saw, that you saw today, Rita, in the hospital. So acute liver enzymes, elevated bilirubin, and encephalopathy. 1, 2, 3. There's some different definitions about timing. Here it talks about jaundice. That patient really wasn't jaundice, just had an elevated bilirubin, as I recall. But you need to be thinking acute liver failure quickly, early, to do these types of interventions. But look at all these different causes of acute liver injury. So this is why when a person comes in with acute liver injury, you always order acetaminophen level. You always get a blood alcohol. But there's this new test called PEth, P-E-T-H, that allows you to look back for alcohol use over 6 weeks. Blood alcohol only tells you if they were drinking in the last 24 to 36 hours. Wilson disease, everybody gets a ceruloplasmin. Every patient, you look at their eyes to see if they have a KF ring. You all know what KF rings look like?
Yep.
Right, good. And you can always ask your gastro to help you with that. Blood pressure history. Did they have any episodes of shock, hypotension, cardiac arrest? Do an infection workup, autoimmune workup. Everybody gets a hepatitis A, B, C panel, serology, minimum. And obviously, if somebody's got hepatitis B, you're going to check delta in those patients if they have acute liver injury. You're going to take a really good drug, herbal history, supplement history, hilly, dilly, silly. Sound good? right, gut coagulopathy gets built into this. Oops, sorry, no, that's going so fast. It's really elevated bili, abnormal mental status, high liver enzymes. You move down this route very, very quickly. If they're developing grade 2 encephalopathy, you're going to be moving them to the ICU to manage their encephalopathy and have, aggressive management. Glucose on everybody, just because with acute liver injury, they can get very low blood sugars. We talked yesterday about phosphorus. You got to check a phosphorus every day. And if the phosphorus is low, you aggressively replace it. You start getting tags as soon as the INR goes up a little bit. Tag becomes your standard way to assess the coagulation system. And of course, liver panel. And monitor creatinine. This patient we talked about yesterday had a really high creatinine. That's really classic for acetaminophen. Acetaminophen is not just liver toxic, but it's renal toxic. So that whole combination looked like alcohol acetaminophen to me. And then we had one other item, right, that was on the differential.
Fatty liver.
Fatty liver, yes. So underlying liver disease is going to make everything worse. Higher risk for getting worse, right? So I'm just pulling out my RMC folder. Okay, let's just go through this and we can wrap up with Bill and Layla in a second. Once people are in a grade 4 coma and we think they're transplant candidates or even grade 3, we would be calling UCSF or Stanford for transfer. We are working with both of those transplant centers. I think in the past, did you send everything to Stanford or did you use both centers?
I think they try to cast a wide blanket and whoever is willing to take the patient. But I think usually they start with Stanford.
We're going to try to use
as well.
We're going to try to use both. There's been a long history of having trouble getting people into Stanford and not having great communication. So a little competition here, I think, is going to get the service level a little bit higher. So this patient, I talked to Ruby yesterday and read it you today about nutrition. When you have acute liver failure, these people need between 2,500 and 3,000 calories a day. There's no way they can eat. They're a little confused. They're having DTs or withdrawal or something else. So it's very important to give all these acute liver failure patients tube feeds. I don't like TPN. I do like lipids because lipids, to rebuild liver cells, you need to be giving people lipids. They need that phospholipids and lecithin and everything to rebuild the liver. You can't just get enough of it by tube feeds. Were you able to get tube feeds started on that patient?
Let me just check here real quick. He should be on 2 feeds. He's actually on a clear liquid diet.
Should have a tube in yesterday. So get that tube in, get the tube feeds going, get to 2,500 kcals a day. This is urgent. This is not just standard of care, but it's about trying to save their life. With the alcohol history, this person's not a transplant candidate. Now we think it's alcohol, fatty liver, acetaminophen. You know why the tube feeds didn't start yesterday? Did any resistance from nursing or the patient or hospitalist?
Usually it's ordered by the hospitalist. So yesterday I texted the hospitalist to get it placed. So then after that, I don't know what happened.
Let's follow up on that and be a little bit more aggressive, because a lot of times you go, oh, I asked the patient and they didn't want it. We don't, this is not one of those things where you ask the patient if they want it or not. This is where you say, this is standard of care. We need to feed you. This is going to help save your life. If you need my help to get that done, let me know. That sound good?
Sure.
So we ordered a tag on that person yesterday, I hope. I can't remember if we talked about that or not, but we ordered an alpha fetoprotein, lactate. Oh, lactate and AFP, did those come back?
Let me just check here real quick. LDH, is that what you're asking?
Lactate, lactic acid, and
lactic acid.
alpha-fetoprotein.
So the lactic acid is, sorry, give me 1 second. Sorry.
Yeah, I have a patient.
The lactic acid came back as 0.7,
That's good.
and the AFP is not back yet. It's still pending.
Since you got the labs open, what's happening to the AST and ALT?
So those two today, the AST is 955, down from 2000. The ALT is 1891, down from 3500.
That's really good progress. And what about the bilirubin? Has that gone any higher?
The T-Billy is remaining stagnant at 1.2. It was 1.2 yesterday, and then on the 14th, it was 1.0.
So this is really good prognosis for this patient. And I'm going to reverse what I was saying about the tube feed. Is just get them on a regular diet, six meals a day, 6 snacks a day. And let's just start feeding them.
Okay.
Make sense? That'll save a little bit of trouble. We want to keep the tube feeding in our pocket. And the phosphorus is still normal, right?
Give me one. Yes.
And finally, what's the creatinine doing since we started MOA? Or did MOA get started yesterday? That was one of our recommendations.
Yeah,
So
I ordered those yesterday, started yesterday.
Oh, good. So you got to order it. That's good.
so the creatinine is at 1.4. Wait a minute. That doesn't look right. The way these labs show up, it's just kind of funky. The creatinine is at 3.19. So he came in with like an AKI starting at 2.8, and it's trending up. At its highest yesterday, it was 3.46, and now it's trending down to 3.19.
All right. This is really good news for this patient. I think this person's going to turn around quickly. You'll be able to stop the MOA tomorrow, feed the patient. And how bad are the DTs withdrawal?
He looks pretty good today. He's alert and oriented ×2, and he's not tremulous at all.
Good. All right. This person may get out of the hospital in a couple of days. Good care. Any questions on that case?
No, I think I was just going to ask you, other than all the, the good workup that was started yesterday by both of you, should I just continue to obviously monitor those and sort of, maybe this is helpful for Ruby to hear as well. Do you want us to touch base with you like at a certain time during the day to round on active patients with you, or do you want text? How do you want to go about just checking in on patients?
Just text me in the morning, figure out what your schedule looks like. I'll tell you when I've got a 15, 30-minute opening, and we'll review it sometime before you all go home.
Okay.
What's your day like? How many hours are you working? Are you doing 8-hour, 12-hour? How do you do this?
Our average day is anywhere from 10 to 12 hours. Just depends on the volume of patients. Right now, I don't believe the hospital is accepting any transfers, but we still get consulted a lot. It sort of just goes day by day. Sometimes we can be slammed, and other days you might have 1 or 2 consults only, but you still are rounding on for both teams and now for you.
Good. So I think if that's okay with both of you, just text me in the morning. We'll figure out when you're going to see the patients, when you've got an opening, when I've got an opening. We'll get it worked out by text. That sound good?
Yeah, sounds good.
Perfect.
All right, we'll just go through a couple more here. We have about 1 more minute. I want to wrap up at 3 if that's okay with you. King's criteria. Obviously, the thing that we're missing on this patient that came in is getting a pH. I didn't want to push yesterday to get a pH because it means getting a blood gas, an arterial stick. If this patient was getting worse, we would be getting a blood gas today, and we'd be getting a TEG. We don't need to get either one right now, in my opinion, but just keep that in mind of what we would be asking for if somebody's getting worse. Does this make sense?
Yes.
Yeah.
Acetaminophen, NAC, we put the patient on. I basically give N-acetylcysteine for 3 days to anybody in acute liver failure, and I'm relatively loose about giving it to acute on chronic. Its use in alcoholic liver disease is controversial. Most people are not doing that anymore. If you have any suspicion about an acetaminophen effect, you just give 3 days of IV, and we discuss whether to change that to oral at day 3 or to stop. NAC, great drug, very useful for liver protection. This is why it's important to take a very thorough history of what medication exposure, because there's a lot of drugs that cause liver toxicity, and some of it's just about taking a good history. Okay, so I think that's a wrap. We got a lot of other things to talk about, encephalopathy and TAG and a lot of other items, but I think this is a good start. What do you all think? Do you have any questions?
No, I think we covered a lot of really good information. It's continues to be super helpful.
Good, and it looks like all the gastros are starting to think about our service, my consultations and things too, and this is great. We're gonna have to do some more advertising, but you too can be part of advertising, just reminding people. They say, transfer to Stanford or UCSF. You say, no, we have Gish, we can do this together as a team, keep them here at RMC unless there's really a need. And of course, I know how I'm transplant certified. I mean, that's part of my subspecialty, so I'll know when to move them with you to another center, but we can do a lot of this locally. Sound good?
Yeah, so just a clarification. I guess the question is, when do we drive the hospitalist to, or even Ruby and I, to plug into you and consult you, like, for example, end-stage liver disease patients, or someone like this, an alcoholic hepatitis patient? Should that be coming to you, or should that be something that the GI docs are comfortable managing? And how much of our use should be pulled into things? I wanted an idea, when is it appropriate to discuss certain patients with you versus others the GI doc should be managing?
Whenever you want to use me, I would say have a low threshold to get a hepatology consult. And remember, the GIs are still going to stay involved with the case. So we're not moving it from the gastros to me. We're just adding my input as a hepatology consultant on top of theirs. And if they want, they can stay very involved, or they can step back and I'll be in touch with you daily. So let's do it. It's called, personalized medicine. But I'm available 24/7. The only time I'd say midnight and 5 in the morning, I'm in a deep sleep. It'll probably be a little bit of a challenge waking me up, but otherwise I'm very available, love to be involved, and have a low threshold.
Yeah, because I know, like, a patient like Fan Heng, someone like that, I immediately talked to Dr. Nguyen about, like, and he agreed to run things by you on this patient with a large HCC going into the IVC and the aorta and part of the atrium. But like someone like Villanova, I didn't know, like, is that someone that we should also, as courtesy, run by you? So that's why I was asking.
You should just say to the gastros, Dr. Gish is always available, loves to consult on cases. He can add a lot. What do you think?
Okay.
Yeah, yesterday it was like this. I think Dr. Chaudhry got the consult first, so I talked to him, and he said, actually, that would be a good patient you should discuss with Dr. Gish. And how about you just consult with him, and then you can round with him. Then he will stay away. Then we don't have to do like 2 consult notes. So that's how we started with this patient.
Great, that makes sense to me. That's the simplest way, right?
Yeah, I think that works. I think because the hospitalist also asked if they should just consult you. And so that's how we figured out yesterday. They consult GI first, and then if they think that we should get hepatology involved, then we consult you. What
we can do too is, this is something that's morphing over time. So let's continue to have dialogue with everybody. And the gastros might say, simple liver patient, don't worry about GISH. Complex, he'll do everything with the PAs and the hospitalists. And if it's somebody that's a little bit in between, say a GI bleeder that needs a scope, will be hepatology, and you'll talk to GI about it, right? So it'll be case by case, and we know the two ends of the spectrum. So I don't want to set one rule. If you're all okay with being flexible.
Yeah, no problem.
All right, so one final wrap up. How about our HCC patient? How's he doing today, and where are we going?
I mean, he continues to be clinically stable and alert and oriented, and I mean, his vitals are all stable as well. I'm just sort of looking at the sign out I got from Ruby that you were CC'd on yesterday. We're just monitoring his labs, and from the standpoint of his liver, his T-billy continues to trend up today. It's at 3, up from 1.7. The D-billy is 1.8, it's up. The AST is at 1900, the ALT is at 831, and total alphos stays the same.
So the enzymes are coming down, right?
No, they're actually, other than the ALT and and total alphos, everything else is trending up.
Okay.
And the INR is going, it went up today at 2.14
But
from
that's
2
the
yesterday.
that patient we got a tag on, and the tag looked really good. So I would say tomorrow, get another tag tomorrow.
Okay.
And then I think that the liver is going to take another hit from the TACE, but the bilirubin's really our liver function test, and continue to track the direct bilirubin and looking for encephalopathy each day. So asterixis, mental status exam. I'm trying to get palliative care to see the patient as an inpatient, and radiation oncology to see the patient. Because I want to know if radiation oncology even wants to offer this patient treatment. If they don't want to offer treatment, then the only other thing we can do is Y90. So this is really, we really need a multidisciplinary team, and we need radiation oncology and palliative care to be involved. But that's a challenge at RMC because they both said call us when they're an outpatient. So I'm going through the medical staff office to try to get them to stimulate inpatient consult, specifically on this patient, but also as part of our system.
So
I
I sorry to interrupt, but with oncology, and I don't know, I mean, I certainly know with oncology, if patients are not, he's Medicare. So if they're uninsured and Medicare, the lower likelihood they're gonna see the patient.
But with telemedicine, all they have to do is dial in, look at the chart, talk to you all, or talk to the hospitalist, look at the x-rays, and make a decision, right? When I'm saying come in to see the patient for radiation oncology, they can do everything by telemedicine. But I'm going to continue to work on that with the CMO and the medical staff office, and I'll be back in touch. I might even have more information tomorrow.
Okay.
Let's talk about it again tomorrow and continue to monitor function. Get a tag tomorrow, liver panel, direct bilirubin, mental status, enzymes, and we'll see where we are. There's no need to do any follow-up imaging quite yet unless his clinical status changes. He is at risk of rupturing that HCC, although it's less now. That would be something to just be aware of.